Okay. Hello, everyone, and welcome. My name is Michael Steck, and I'm a program manager with the New Jersey chapter of the American Academy of Pediatrics. Today's webinar will present the Safe Environment for Every Kid model, or SEEK, with Dr. Howard Dubowitz. Dr. Dubowitz is a professor of pediatrics and director of the Center for Families at the University of Maryland School of Medicine in Baltimore. He has served on the Executive Council of the International Society for the Prevention of Child Abuse and Neglect and the National Boards of the American Professional Society on the Abuse of Children and Prevent Child Abuse America. Dr. Dubowitz is a clinician, researcher, and educator who has led the development of the SEEK model. A few notes before we start. Today's webinar will last 1 hour. All attendees will be muted throughout the webinar. If you have questions during the presentation, please submit them through the Q&A box on the webinar control panel located either at the top or bottom of your screen. Any questions remaining unanswered at the end of the webinar will be compiled and answered, provided to participants a few days following the webinar. Additionally, you can address your questions to Dr. Dubowitz directly using his email address at the end of this presentation. The webinar is being recorded, and all registered participants will receive a link to the recording when available. Now it is my pleasure to turn the webinar over to Dr. Howard Dubowitz.
Thank you, Michael, and thank you all for coming in the middle of what I'm guessing is a busy day to hear about the SEEK model and also the study that we're launching. So my plan today is to give you a little bit of a background to what got us going down this path about 20 years ago, show you some of the data, just a little bit, that we gathered through 2 big randomized controlled trials, and then introduce to you the study that NIH is funding and that we are still very much interested in recruiting primary care practices who would like to join us. So let's see, oops, that did not work. Moving this along, sorry about that, but I thought we were all set, and oops, okay, that something worked, not sure what. Okay, so here is really quite briefly the conceptual model that got us started. And I've been doing primary care for many years, and also with an interest in child abuse and neglect. And it seemed that we had gotten moderately good at responding to the problem of abuse and neglect after the fact. But wouldn't it be so much better if we could help prevent this problem in the first place? And so it seemed that if we could do a better job helping address some of the social determinants of health. This was 20-some years ago, before the term, I think, has gotten rediscovered. That if we do so, that we can help support parents and parenting. At the same time, we'd be strengthening families, and that in turn should promote kids' health, development, and safety, and help prevent child maltreatment. So here you see the cascade of good things that the SEEK model attempts to set in motion. So why is primary care a terrific opportunity to promote kids' health, development, and safety? It's well accepted. Most parents, most of the time, know that they need to bring their kids in for these visits. So it's something that's institutionalized, and we're not talking about having to build a whole new infrastructure. As you know, especially in the first few years, there are lots of visits, and the goal of prevention has actually been at the heart of primary care for a long time, as has the concern for both the child and family. It's pretty humbling to consider that in 1905, the father of American pediatrics, Jacobi, wrote beautifully about it not being enough to be narrowly concerned with just the child in front of you, but that naturally we also had to think about the family, the environment around that kid. Most of the time, I think in peds and in primary care, we have a good relationship with families. We like them, they like us, and we have good cred, they trust us, and that positions us really well to know something about what's going on in the family. So unlike our colleagues in the behavioral health, social work, child welfare, we don't face the stigma that they often have to overcome. So arguably all of this does add up to the opportunity to promote kids' health development and safety. And I'm suggesting if we have this opportunity, we have a responsibility to try and play a valuable role. So hope this is persuasive as to why primary care does offer such a good opportunity. Let's move to the SEEK model, and it begins by recognizing that many of us may not have been trained in how to address some of the psychosocial problems that SEEK targets, such as what to do if there's domestic or intimate partner violence or a parent is abusing drugs. And so the model includes training, which is now available through videos on our website. We developed this parent questionnaire, and I'll come back to that in a moment. And then the idea is that there's a brief assessment of identified problems. And from the get-go, we had an advisory committee of neighborhood health center docs in Baltimore who taught me the KISS principle, keep it simple, stupid. And so we couldn't delude ourselves into thinking that in a busy practice, folks would have 15, 20 minutes to assess possible problems. And so we've worked hard at prioritizing what is the key info that should be assessed. We've incorporated principles of motivational interviewing, which we think is such an exciting advance in healthcare. For the longest time, our model has been to tell folks what they need to do, but we've learned that very often that does not work well. And so this fundamental shift in practice, where we elicit from the parent, sometimes the patient, what they think about the issue, what they think they were able to do or would like to do. And so instead work with them in a partnership. These are some of the principles that we've incorporated. And then the idea is that we initially help address problems. This is recognizing that very often help will be elsewhere in the community, for example, for domestic violence or substance use. So what you see here is the idea that with some knowledge and skill, we can still play a potentially pivotal role in the life of this family in a few strategic minutes. The question comes up of how much of this should be done by the PCP and or one of these other folks that you may or may not have in your practice. I will say that it's ideal to have the help of one of these folks, but at the same time, the model is such that it can be implemented without them. And we have been deliberately flexible about how this is done. So even if you have, let's say, a social worker, some PCPs really are interested in tackling these issues, others less so. Or it might be that you're having a really busy day and you're grateful for the help, or there's a no-show and you're happy to give a warm handoff to the social worker or the like. Sometimes the parent who really knows and trusts you may prefer speaking with you rather than someone else. So we defer in this model to you to decide how best to handle different situations. It does require being savvy about what are the resources in your community, and we're able to help with that. And finally, we developed Seek parent handouts with the idea that they be customized to include info on those local resources and also info on your practice. So this is a quick sketch of the model. Here you see the problems that Seek targets, and at a glance, you'll notice it's not everything. And this is an ongoing conversation. Folks around the country, and I might mention that Seek is being implemented in 19 states. Some are eager to add other problems to this list, and we have been flexible in this regard. So for example, in Texas, some practices have added a question about a gun in the home. I think in Utah, they added a question of difficulty with transportation. But I think recognizing the time constraints in a busy practice, we've thought that if we prioritize these problems, if we can make a difference regarding these, that we can move the needle and substantially help many families do better. So here you see the Seek Parent Questionnaire, which was revised a couple of years ago. And it's based on evidence from the 2 randomized trials that I mentioned, as well as from experience that we've had from folks in the field implementing the model. Importantly, it's brief, easy to read with yes/no answers. It's convenient because there are always a couple of minutes that families are waiting for us. It's voluntary. Parents are told they don't have to fill out or respond to questions they'd rather not. It's confidential unless we're worried about the safety of the child. And again, I mentioned the flexibility in terms of content, but there's also flexibility in terms of timing. So I don't think we or anyone has actually cracked the nut of when is the right time to ask these questions. We do recommend often doing it at, for example, the 2, 9, and 15-month visits, and then annually through age 5. And at the same time, if one of those visits is already really busy, it's fine to ask it at a different time. It is important, however, to ask the questions somewhat repeatedly. 1, situations can change over time. 2, parents bringing their kids in for regular checkups may often not be familiar with being asked these questions, and at first may feel uncomfortable disclosing potentially embarrassing info. But think about it, you're signaling something really important to the parent, even asking these questions, that being, I'm interested in you and your family, and if you have one of these problems, I'm a resource that you can turn to and we'll try and help. So those are some thoughts about the questionnaire. But very importantly is, how do we introduce this? Because how we frame it can really make a difference. So it starts off on an empathic note. Being a parent is not always easy. How's that for understatement? It's universal. We're asking everyone. It's not because I'm worried about you using drugs. Rather, we're asking everyone. Providing the context, wanting to help families have a safe environment. And conveniently, it builds on what's long been accepted, our interest in preventing injuries and keeping children safe. Again, it's voluntary and confidential. All of this is briefly spelled out in the intro. So how does the SEEK model work? At the start of the visit, the parent is given the questionnaire. They complete it while waiting, and then give it to the PCP at the start of the visit. Again, as I mentioned before, the identified problems are then addressed by the PCP and or one of these other folks that you may have as part of your practice. Again, you have the SEEK parent handouts, which I should say are pretty simple ones. So with all due respect to our AAP, I think quite often those handouts require a year or two of college or a highly motivated parent. And we opted to have ones that just simply convey a few key messages. There may be the need to refer to community agencies and also for follow-up. And for some of these problems, it really might be more appropriate to suggest to the parent, you know, this is something really important for you to discuss with your own doctor or nurse practitioner. Let's just say a positive screen for depression. So this is a quick overview of SEEK, the model, and how it works. And I could pause for a moment and see if there are any questions so far.
No questions so far, Doctor.
Okay. So I want to briefly show you some of the evidence, and this is condensing 16 or 17 years of work into just a few minutes. But the first study was done in West Baltimore, a rough, tough neighborhood, in our continuity clinic. And as you see, low-income African-American families. The second was in a very different setting. So this was 18 private practices in central Maryland, families averaging over $70,000 a year and mostly white. A relatively low-risk population. By the way, I might add interesting because seldom is this kind of research done in such low-risk samples. So the first big hypothesis was that by training the PCPs, that we could significantly improve what you see here. We thought that this was the critical first step. If we were not able to change this, we were unlikely to be successful. So I'm just going to summarize some of the findings, and we were encouraged because we generally did find that their attitudes and behavior regarding the targeted problems had improved, and this was based on what they themselves said, reviewing the kids' medical records, and directly observing them. So we had med students in the second study sitting in the office observing 3 checkups of each PCP at the beginning and end of the study. These findings pertain to both the first and second randomized control trial, and very importantly, they were sustained for up to the 36 months that we followed them. This is important because you probably know that so often in these studies you get that initial blip and you're all excited, and then sure enough, over the ensuing months, it gradually fizzles. So this was for sure encouraging. The next and main study hypothesis that the model would help prevent kids from being abused and neglected. And this is tough to measure. So we had parents self-report on how they handle difficult situations with their kids. We again reviewed the medical records and were able to access data from the child welfare system. And I'm going to just show you a little bit of this. So this is where parents report on something called the conflict tactics scale, how they handle challenges, let's say. And if you focus on the right at 12 months, you'll notice that the SEEK group in blue, the moms reported fewer physical assaults compared to the control group in yellow. I should add, it's not like this is a huge difference, but at a population level, if we were able, again, to move that needle, even by 4, 5, 6%, many, many kids and families can benefit. Here, we looked at non-compliance documented in the chart, and this is over the roughly 30-month period of the study. I should add that we did not teach in this case, residents to document non-compliance. And even though the problem is quite frequent, I think usually there's a pretty high threshold before folks actually document those words, that word. And so you'll notice that the rate of non-compliance was roughly half in the SEEK group compared to controls. We also looked at documentation of delayed immunizations, and here the finding was even a bit stronger. We then looked at CPS reports, and this is in the inner city West Baltimore sample. And you'll notice that the SEEK group, those exposed to the model, that about 12% were reported during that 30-month period, compared to 20% of controls. And by the way, very, very few of the reports came from health providers. This translates to helping prevent a report for abuse and neglect in roughly 1 out of every 13 such high-risk families exposed to the SEEK model. This was actually a finding stronger than we anticipated. One of the questions that often crops up is, okay, this sounds good, but what about the time that it takes? And so we had those med students with a stopwatch checking how much time did PCPs spend on psychosocial issues. I'll start with the bad news. On average, not much time. You see roughly around a minute. The good news is that on average, SEEK did not add much time. And so, bear in mind that very often parents do not disclose problems, and by having them fill out the questionnaire in advance, it can obviate the need to cover that territory during the visit. I should also say that the model was done with a social worker available, and so that may have offset some of the time required of the PCPs. And then we've looked at the cost analysis, and this paper is under review. And here you see that it cost approximately a couple of $100 for each case of abuse and neglect prevented. And using a very conservative estimate of the medical and mental health care costs, you can see that SEEK is cost saving. So just to summarize these findings, we think we've found out that pediatric primary care does offer that terrific opportunity to help address these problems that face so many kids and families. That it offers a practical model to improve care. This has been implemented in many different kinds of settings. I've shown you some of the evidence that SEEK can help reduce abuse and neglect and harsh parenting and help promote kids' health, development, and safety. Again, that it appears cost-saving, that it did not significantly increase time. And at the same time, we think that there is a need for further evaluation, and that will take me to the last part of the presentation, discussing the new study. I do want to just mention this paper as a recent pub in pediatrics, and it's a nice review of different methods, measures, tools for screening for social determinants of health. So I think we all know that this has become a hot topic in recent years, and we recognize that there are a variety of options that you have, and at least would recommend this review to get some of the, at least the authors' ideas about these alternative measures. So before I go on to the National SEEK study, let me again pause for a moment and ask if you have any questions so far.
No questions in the queue, Doctor, at this time.
Okay. I think the plan, if I understand correctly, is that that when I'm done, we'll have time for Q&A then. So I'm going to tell you a little bit about this new study that you see funded by the National Institute for Child Health and Human Development for 5 years. And the original research was done in pediatric practices. Lots of kids around the country are also seen in family medicine practices. And so we're interested to study the model in those too. So what are the overall goals? So this research fits within a newish field called implementation science. And briefly, what this is about is 20-some years ago, the NIH recognized that they invest a ton of money in developing various treatments, interventions. But typically, there's a long lag time before even something that has been found to be effective or pretty promising is widely adopted. And so implementation science attempts to learn what is it that facilitates or impedes the adoption, the implementation, and the sustainability of innovations in healthcare. In our case, all of this is applied to the SEEK model, and at the same time, an opportunity to again probe its effectiveness in helping prevent child maltreatment. Broadly, we're hoping this will help improve primary care and also contribute to this newish field. More specifically, what are the aims? So we're going to compare two increasingly common approaches to medical education. So as you know, the board, rightly or wrongly, has foisted upon us the MOC4 requirement for maintaining board certification. And what's interesting is that there's actually been very little research on how this modality of medical education works. The independent here refers to the modality where, let's say this evening, you could go at your convenience online, you could view some training, take a test, and get credits that way. And that too has become quite common, and that too has actually not been well studied. So we have a good opportunity here to compare how these two approaches to medical education work. Again, we're going to be examining SEEK in both peds and family medicine practices. Again, examining its effectiveness in preventing maltreatment, as well as the economic costs of implementing the model. So you may be asking, okay, sounds pretty interesting. What do practices receive for participating? Here are the bennies that we think you potentially will get. It's an opportunity to improve your practice, to provide more comprehensive care, as Jacobi said over a century ago, to be concerned about the family surrounding that kid. So SEEK is an attempt to walk the walk. Using this questionnaire can also be valuable as a needs assessment, because very often, without asking, it's hard to know just how prevalent is, let's say, food insecurity or substance use in the families you serve. There's the training of PCPs and the different credits for free access to all the SEEK materials. Access to a social worker staffed helpline. And this is someone who will consult to PCPs and staff on different issues that might crop up, but will not work directly with parents. This person can, by the way, also help identify local resources, as well as customizing those SEEK handouts. Implementing SEEK can help you qualify as a parent-centered medical home, and that has the potential for added reimbursement. And as part of this study, we're able to pay practices $2,000 a year to help cover some of the related admin costs. There are also possible increased revenues through the CPT code, which is a couple of years old now. And this, if you're not familiar with it, covers care provided to parents during regular child well visits. The reason that we have possibly there is because this varies across insurers and states. So you would need to check locally to see what you stand to get reimbursed. There's the waiving of any license fee for implementing SEEK. And last, and hopefully not least, we think this is a nice opportunity to help advance practice and knowledge regarding primary care. So, what can I say? We're hoping that this is somewhat persuasive in encouraging folks to join us in this study. So what does participation require? And I'm going to use the example of PCPs. It's a little different depending on one's role in the practice. So if one was a practice leader, there's some other tasks. If one is a behavioral health professional, that too would be different. And we are also recruiting a few office staff. But this will give you at least a reasonable sense of what's entailed. So let me first say that we're very mindful that life is not dull, people are busy, and we've worked hard to minimize the burden on respondents, but it is a study and we need to gather some data. So here you see that there are these 4 online surveys over the 2-year period that the practice would be involved. Sometimes the really valuable info cannot be gathered with checklists and surveys, and so there's a qualitative aspect to the research, and we're going to invite a subset of folks to 3 phone interviews during the 2-year period. It does mean accepting randomization of the practice to one of the 2 training approaches. And again, the independent one is pretty much where the PCPs would go online for a couple of hours and view the Seek videos, hopefully pass the test, and that would be it. The MOC4, or for family medicine, it's called performance improvement, has that online training as well as conducting a QI project. And it includes 3 one-hour webinars that I lead over a 2-month period. I will add that I think, if you're not already pretty familiar with how QI works, that this is a good opportunity to learn about it, and this should really be useful for introducing other innovations in your practice down the road. And lastly, it includes implementing the Seek model in your practice, and just to recap, it means administering the parent questionnaire for selected checkups, again, briefly assessing, initially helping address problems, and as you see, with or without the help of one of these other folks. And then using the Seek handouts, or I should mention, if you already have alternative handouts that you like, that's fine. So what are the next steps? If you're interested in possibly joining us, I want to encourage you to please explore interest of others in your practice. And if you could let us know within roughly 10 days, we'll be happy to set up a webinar really quite similar to this one with others in your group. As an alternative, because we realize that quite often it's hard to get folks together, given scheduling, we can send you a link and people can view the webinar at their convenience. Some have said to us, boy, this sounds really interesting, but the timing is bad. We just introduced this new EHR, we're all going crazy. And so for them, we're asking if we can contact you later this year. We actually plan to continue recruiting practices through the end of 2020. So that is an option. Lastly, some have said thanks, but no thanks, and for whatever reason, not interested. And in this kind of research, we actually need to learn from those who opt out. And so we're requesting really limited participation, mostly to learn what is it that influenced your decision not to participate. And I'll say for the last time, we're again hoping that you will certainly consider and join us. But if not, there is this final option to just give us a little info so that we can learn from you regarding that. So that ends what I've prepared for this presentation. And now you are on, and we have time for any Q&A, any questions, thoughts that you may have. Michael, you with me?
Yes, doctor. I'm just waiting giving the participants a chance to
Okay.
to type in something if they need to.
Okay.
So there's nothing in the queue at the moment, doctor.
Okay. I guess we'll wait a minute or two. Maybe someone's gathering their thoughts. I'm still not totally in love with webinars where you don't see anyone. So I'm speaking to a monitor, and I guess I'm old-fashioned. I still really prefer face-to-face.
Sure.
So I don't know who's there or what they're thinking.
Understood. Okay. So there's nothing in the queue, doctor.
Okay. Well, I think those of you still with us, you can see here my email as well as my phone number. And if you later think of any questions, if you'd like to consider the possibility of participating in the study, please let me know, and be happy to talk some more and give you a more complete sense of what's involved. And also, I should add, without the study, if you're interested in Seek, I realize I don't have the website, I think, anywhere up here. And I'll just mention it, that it's www.seekwellbeing.org. And I would encourage you to check out the website. There's a lot of info and FAQ section there that could be quite useful.
Okay.
So I gather there are no comments or questions, and I said
nothing in the queue, doctor.
Okay. So I think, not to keep people hanging on, I want to again just really thank you. Thank the New Jersey chapter for helping organize this. Thank you, Michael. And thank you for joining for this webinar, and hope to hear more from you. Thanks so much, and enjoy the rest of the day.
Thank you, doctor.
Okay. Bye now.
Okay.